very, very warm welcome to you all. Good morning, good afternoon, and good evening to everyone across the globe. I, Anita Jatana, consultant dietetics in the Crest Apollo Hospital, Delhi, would like to extend a very warm welcome to all our esteemed speakers, chairpersons, and participants for another Gap Year session, which is in collaboration with Global Dietetics Community. Would like to welcome our esteemed speakers. I think we've heard them many times before and we've met her personally. And Dr. Zulf is what he likes to be called, and Professor Tilkawati. So Dr. Zulf is an associate professor at Dietetics Faculty of Medicine and Allied Health Sciences. He's from Hospital Sultan Abdul Aziz Shah University, Putra, Malaysia. And we have Professor Dr. Tilkawati, Faculty of Medicines and Health Sciences, School of Biosciences, Taylor University, Lakeside Campus from Malaysia. Would like to extend a very warm welcome to our chairperson, Dr. Sandeep Saxena, who's a very busy consultant, nephrologist, and transplant physician at Apollo Hospital, Indore, and moderator, Babita Hazarika, who's the chief dietitian at Apollo Hospitals, Kolkata. The session today is on besting dietetic services practices for kidney patients. And today is a very valid and challenging topic for the dietitians today. And we all know it and we face it every day in our day-to-day practice. As you all know, CKD is on the rise and is a progressive condition. And it's really upsetting because sometimes when they ask you, will I get better with diet control? You feel such a fraud because you know it is progressive. And the condition that affects 10% of the general population worldwide accounts to more than 800 million individuals. And data from the International Society of Nephrology's Kidney Disease Data Center study reports a prevalence of 17% in India, which is high. Main cause, of course, 2/3 of the cases on CKD are due to diabetes and hypertension, which is so controllable, but it still progresses to CKD. In Western countries and in India too, diabetes and hypertension today account for 40 to 60% of cases of CKD, and both are on the increase. Prevalence, of course, in Delhi, we are the capital in India, and we account to 7% and 17% of hypertension in India. Of course, the other reasons we know as per ICMR data are glomerulonephritis, polycystic disease, genetic obstruction, etc. Then we have malnutrition, a very big problem faced by these patients, which is prevalent in both developing and developed countries, and is an important risk factor for morbidity and mortality. Using the FGA, a recent study found the prevalence of protein energy wasting in 31% of patients with CKD, and prevalence of 20 to 45% have been reported in various studies in children with CKD. While malnutrition in general population might result from decreased intake, malnutrition in CKD is not entirely explained by reduced nutritional intake. Very, very different. A delicate interplay of multiple factors, including hormonal imbalances, decreased appetite, food intake, low food intake, chronic inflammation, increased protein catabolism, with decreased anabolism, metabolic acidosis, nutrient losses in diastole, and metabolic derangement predispose CKD patients to malnutrition. So many things you can handle one, but you can't handle it all. Like it's so many of them. So a clear understanding of the pathophysiological mechanism of nutrition in patients with CKD is essential to planning strategic interventions to improve growth and development in children and mitigate negative clinical outcomes in these patients. So, and to understand this difficult situation and answers to the problems, we have Professor Dr. Zulfitri, who is going to speak on assessment of malnutrition in CKD, incorporating bioimpedance analysis and phase angle of nutrition diagnosis, and Professor Dr. Telkawati, who's going to address malnutrition treatment and how does nutrition support achieve those results. Would like to introduce Dr. Sandeep Saxena, who's MBBS from GMC Gopal University topper and several gold medalists over there. He's MD from MAMS and nephrology from AIMS Delhi, clinical fellowship nephrology from University of Toronto, Canada, with several national and international publications to his credit. has done more than 1,000 kidney transplants both in Canada and in India, and is presently consultant nephrologist and transplant physician at Apollo Hospital in Indore. Welcome you. And Babita is a chief dietitian at Kolkata with 3 decades of experience in the field of nutrition, with special interest in critical care, master trainer, postgraduate diabetic educator, certified course Project Hope, USA, state level winner in excellence in medical nutrition therapy, written chapters in clinical nutrition books and publications in general. Would now like to take this forward and introduce the speakers. I'll do the honors. Just a minute. Dr. Zulfri is academic dietitian, currently serving as an associate professor at the University of Malaysia. He's deeply committed to advancing the role of dietitians in nephrology practices and is recognized for his influential contributions in renal nutrition across Southeast Asia. He's got huge number of publications. He's currently the Allied Fellow of Center for Quality Assurance, Head Department of Dietetics, Faculty of Medicine and Health Sciences, Head Department of Dietetics, Hospital Sultan Abdul Aziz Shah at Malaysia. His education, of course, is PhD and MSc. He is a registered dietitian and a certified level dietetics from US or the International Society of Management of Kidney. He's got several publications to his credit, chapters in books and books that he's written with a lot of research grants. So over to you, Dr. Zulfi. Yeah. We'll start your session. I'll request everybody to be muted and put your questions in the chat box.
Thank you very much, Dr. Anita, for your kind introduction and also invitation to share with my fellow healthcare professionals in India, right? So I will be talking about assessment of nutrition status, which special focus or emphasize on using bioelectrical impedance analysis. All right, a little bit of disclosure before I proceed is that I have received the following of honoraria and also research grant from the following institution. So throughout this 20-minute sharing session, I hope that we will be able to discuss some of the nutritional issues that are faced by our CKD patient and why is it important to measure body composition among this population, and also have some introduction a bit about BIA and how we specifically focusing on the use of phase angle in order for us to help in the diagnosis of protein energy wasting in this population. So ladies and gentlemen, I would like your favor though, if you can pull out your cell phone, yeah, and then you can scan this QR code, or if you are accessing through your computer, perhaps if you want to go to your browser and then type www.menti.com and then enter the following code 69979099. We have some interactive session afterward that I would like to hear from the fellow participant as well, your opinion particularly, right? Okay, so I can see that some of you already put a thumbs up, meaning that you are already joining in.
Everybody scans it. Yeah, just give them a minute.
Okay, I'll give you a minute.
Okay, let's start. Yeah.
Okay.
Yeah.
All right. Thank you very much for joining this. So let me scan for myself also. Okay. All right. So I would like to ask the audience here about this. name one of the common nutritional issues faced by advanced CKD patient that you always see in your practice. What will be the most common nutritional issues? All right. You can actually type in, right? Okay, some of you has mentioned about hyperphosphatemia, high uric acid among this patient, poor dietary intake. Okay, what else?
Malnutrition is what they're putting in the chat box.
Malnutrition. All right. Okay, very good. All right. So malnutrition. Okay, more and more people saying malnutrition is the issue. Okay. All right. Okay, very good. So these are the main issues that in your practice you always are facing this kind of issues, right? So there are a lot more issues when we talk about nutrition issues, particularly among this population. Yeah, to name a few, including protein energy wasting, fluid overload, which is pretty much tied into the inability to control the sodium or salt intake, sarcopenia, electrolyte control, especially hyperkalemia, hyperphosphatemia, and we also seen patient experience micronutrient deficiency, vitamin C deficiency, and anemia, given the fact that that is pretty much tied in to the role of kidney, right? So for this particular session, this 20 minute of sharing session, I will be basically focusing on protein energy wasting. And if we have time, we may talk a little bit about fluid overload. All right. So what is protein energy wasting, or PEW, to begin with? Yeah. Um, PEW, or protein energy wasting, is a specific coin or a term that has been coined to be used among kidney patients. Yeah. And the prevalence of protein energy wasting, as you can see here, as patients progress from early stage of CKD to end stage of CKD, we have increased the prevalence. Right. So how does protein energy wasting is different with other malnutrition terminology? I'm sure that in your practice, have you come across with the muscle wasting, you have come across with cachexia, sarcopenia, and so on. You can see that at the phenotype level, there are some differences that we can make. For instance, all of these actually overlap, but some can be you can identify further looking at the malnutrition, body fat reduction in body fat, for specifically for protein energy wasting. In sarcopenia, talking about the muscle strength, the function of muscle, and so on. And of course, there is overlap in all of these. It looks the same, but it's different. But what makes it different, perhaps if we can look at the pathophysiology, how does it occurs, right? And so in order to understand this, let us take a look, yeah, once what happened when the kidney started to fail, when you have started to reduce your kidney function, yeah. So once this kidney has started to fail, we started to accumulate cytokines, yeah, and all of these triggers a chronic persistent inflammation.
अभी
But
क्लास है रमीना बोली भी
once the kidney is already failed,
Hussein, mute yourself.
okay, once
Sorry.
the kidney, or thank you very much. Please mute yourself. So once the kidney is already filled, we put the patient on dialysis most of the time because lack of organ donor. So due dialysis itself is quite catabolic. Yeah, it triggers the complement activation. Patient may susceptible to infection, and they are due to the resources that we have, especially coming from the emerging economies countries. We also have experienced that patients have less dialysis adequacy, the introduction of reuse of membrane, dialysis membrane. All of these actually triggers a cascade of pathway. We call it activation of the UPS pathway, yeah, or ubiquitin proteasome system that lead to muscle degradation. So that factors is called as iatrogenic factors. We also have non-iatrogenic factors that lead to malnutrition. Among others include the nutrition aspect per se. Yeah. Patient always present with poor appetite. They have bitter taste. They have melted taste that trigger the alteration in their taste, and our patient is also struggle in terms of their psychosocial factors. Once they have kidney failure, they lost their job, they experience depression, anxiety, they have a financial constraint. All of these all together, yeah, contribute to low dietary energy and protein intake, and subsequently leading to muscle proteolysis or malnutrition, or to be exact, protein energy wasting in this population. So let's take a look into protein energy wasting prevalence. Was one of the paper published by Carrero Group in 2018. They compiled all the prevalence of protein energy wasting worldwide. You can see from the country that I came from, which ASEAN country, the prevalence is about 52%. And from a bit more higher in India, based on this paper, is reported the prevalence up all the way up to 65%. There are huge variation in the prevalence given the fact that the definition, the criteria, diagnosing criteria is not standardized throughout all of this study. So in our country, for instance, based on our large studies that we have conducted in our country, I think is this 52% is a bit slightly overestimate. So what happened when the patient has protein energy wasting? This has been identified as one of the important factors that lead to premature deaths among this population. You can see based on your figure right here, yeah, once our patient present with protein energy wasting and we don't do anything towards that, we don't do interventions toward that, so they will end up having lower survival outcome as compared to those patients without protein energy wasting. And in fact, when we look into the criteria to satisfy the protein energy wasting, those who's present with more criteria with protein energy wasting end up to have poor survival advantage, yeah, as compared to those with less criteria of protein energy wasting. I'm going to go through about that criteria slightly later. So I would like to ask, based on your cell phone just now, I would like to ask this question. Can obese individual or can obese patient be malnourished? What do you think about it? Right? Okay, some of you are saying yes, some of you are saying no. Let's see what the rest of you think about this. By the way, if you haven't really joined this, you can go to your browser and just search www.menti.com, and then you can key in those codes 69979099, right? Okay, well done. So majority of you think that obese individual can be malnourished. Right. Let's take a look into the literature on this. Right. So this is the typical graph pertaining to the relative mortality or risk of mortality that we always see in general population like you and me, right? As you have putting more weight or you become more overweight and obese, the risk of mortality increase consequently, right? The same goes if you go thin, very thin, yeah. The risk of getting infection is increased, so the risk of mortality is also increased. But this is what we have seen in advanced CKD patients, that their relative risk of mortality is reduced as they become more and overweight and obese. But what is the actual reason why we have seen this what we call as obesity paradox among CKD patients? Before we even go further looking at that aspect, let us take a look into this body compartment aspect first. Previously, when we talk about nutrition assessment and measurement and anthropometric assessment is one of the component, we always look at the BMI, yeah, but we know that our body weight is more than that, yeah. It's not just about the weight per se, and we know that our body is comprised of the solid and fluid component, and within the fluid component there are intracellular fluid, extracellular fluid, and within this fluid a solid component. It can be divided into protein, fat coming, and also minerals coming from bones and so on, right? So it's more than just weight per se, more than BMI per se. So look, for example, looking into this figure, this figure coming from the two different individual, but with about the same BMI. Yeah, one female, age 34, BMI 37, and another one female, age 34, BMI 37.7. You can see what make up their BMI is totally different, in which the one on your right hand side has much more fat mass than fat-free mass as compared to her component, right? So that BMI alone does not really tell the actual story, what happened to your patient. And for instance, this is one of our patients that we work at in one of our center in Bangladesh, yeah, National Kidney Foundation of Bangladesh, with a weight of 92 kilogram, and her BMI is obviously obese, yeah. And we did a hand grip strength among for her, and definitely it's very low, only 10 kilogram. She was activity of daily living, semi dependence, would need help to go to the bathroom and so on, yeah. And when we do nutrition focused physical examination, we saw a bit of apparent muscle loss. You can see the slight depression on the temple. And then when we actually palpate on the bicep and tricep, the muscles feel very stringy and less firm. That's itself actually make it a bit difficult for us to do the skin fold caliper for her, because it's very difficult to separate out the muscle with the adipose tissue, right? So what it does, it tells us here is that by having obese BMI, is not necessarily that this patient is not malnourished, right? Let's take a look into further details about BMI, right? And how does it relate to the mortality graph that we just saw just now. So when we zoom in into the component of BMI, which is the skeletal muscle index in this case, we can see that patients with lower skeletal muscle index have higher risk or higher tendency or higher risk towards mortality as compared to those who could maintain their skeletal muscle index in a very good way, right? So that's definitely explained to us that BMI is not just about the weight, but perhaps more importantly, we have to look into the muscle aspect also. So moving on to my next question is that what are the criteria that we can use to assess protein energy wasting in this population, right? Please try to answer this question. Okay. Some of you putting BMI, some of you putting low serum albumin. How about diet and body fat percentage? Is also one of the criteria that you need to assess in order to assess protein energy wasting. It's um pretty okay. More of you think about poor diet intake. All right. Let's move on to the next slide. Okay. Okay, so this is quite dated already. This is one of the criteria that has been proposed by International Society of Renal Nutrition and Metabolism in 2008. Yeah, and I believe that they are doing a revision of this criteria. You can see here, the protein energy wasting can be diagnosed once the patient satisfies 3 out of these 4 criteria. Yeah. For instance, for serum chemistry, we want to look at the serum albumin, pre-albumin, and also serum cholesterol, any one of these. Yeah. For instance, if they have serum albumin less than 3.8 gram per deciliter, so they already satisfy the serum chemistry component, you want to look at the BMI again, an international weight loss, and total body fat less than 10%. So here is problematic things is that when you incorporate BMI less than 23, when you know that Asian genetically tend to deposit fat at much lower BMI. All right. So then we have muscle wasting, which what we can highlight it here is that you need a proper skill in order to assess the muscle wasting of your patient. You need a proper technique of landmarking using ISAC, for instance, do the skin fold calipers. You need those kind of skills also, right? So then you can also look at the diet intake, yeah, whether your patient have unintentional low dietary protein intake less than 0.8 gram, for instance, for dialysis patient, yeah. So unintentional low dietary energy intake less than 25 calorie per kilogram body weight. So, but again, this would require a tedious assessment. You would need a dietitian to assess this component. So definitely, in order for us to come with the diagnosis of protein energy wasting for this population, is going to be a bit challenging because you require certain skills to identify your patient. Now, we move on to our main research question is that how we can use bioelectrical impedance, which is currently available in many of our institutions, in order to help in assessing the risk of protein energy wasting in this population. And before we go further about this protein energy wasting, I think it's also important to understand a little bit of principle of protein energy wasting. Yeah. So, sorry, of BIA. So basically, BIA apply a small weak alternating current into the body, and it measures the voltage in order to get the value which is non-resistant. So it's basically the function of resistance and reactance. Yeah. So you can see here the resistance is decreased with the increasing surface, while it's increased with the increasing length, right? So with the modern technology of BIA, previously we only use one single frequency at 50 kilohertz. Now we have a multi-frequency of BIA. We can give the patient at different frequency. Yeah, at the uh, basically the current flows by two mechanisms, yeah, basically directly through the fluids and indirectly across the membranes. So in a low frequency BIA, yeah, the current does not pass through the cell, yeah, so instead it's actually pass within or in between the cells, yeah. However, we also have the high frequency, in which in high frequency it can actually go through the cell. So having said that, right, so we will be able to identify the intracellular water and extracellular water when you have multiple frequency of BIA, right? So there are many various BIA device. You have to know what are the limitation of all of each of this device, yeah. um and when you measure the BIA, what are the parameters that you want to look for in order to identify protein energy wasting in this population? So based on the formula for each of this BIA machine, they will be able to calculate the muscle mass or skeletal muscle mass for your patients. So in this case, we have a segmental in which you can look at the segmental aspect of the muscle mass. So what you're going to do is that you can measure at baseline, and then once your patient go through the treatment of, for instance, your dialysis patient go through the treatment, at 6 months, you want to measure again to look at how are they going in terms of their muscle mass, right? So, but I would like to highlight the specific aspect of BIA, which is what we call as phase angle, BIA-derived phase angle. But what is BIA-derived phase angle? So we know that impedance consists of two components, right? Which is resistant and reactant. Resistant is the opposition to the flow of an alternating current through intra and extracellular ionic solution, while the reactance is the delay in the conduction as a result of a capacitant produced by the cell membrane and tissue interface. So the capacitant causes a phase shift or what we call as phase angle. And this can be quantified by the tangent of this formula, right? So having said that, phase angle, on the other hand, is a measure at the cellular level. So it's indicator of the cellular health. If your patient present with low phase angle, that means that your patient have a poor cell membrane integrity, may indicating the cell damage or cell death. This is particularly important if your patient experiencing muscle wasting, with reduction, malnutrition, and also edema, right? So phase angle is increased indicates that you have increment in the muscle mass, you increase in the weight, and you have a good supply of nutrition. But phase angle will be reduced in the case that if your patient have muscle wasting, weight reduction, edema, and in fact overtraining can also cause reduction in phase angle. So there are quite numbers of recent publication that has identified the fact that BIA-derived phase angle was found to be rapid, expensive, and non-invasive biomarkers to detect protein energy wasting in dialysis population, particularly. But we know that these parameters is population specific. So we come up with our own research in order for us to identify the usefulness of using phase angle to detect protein energy wasting. So before we do that, we analyze or we investigate the prevalence of protein energy wasting in our population based on the ISRNM criteria that I've presented just now. And we found out that about protein energy wasting is prevalent in about 1 in 5 dialysis patients that we have. And definitely when we tabulate the phase angle component in this those with PU and non-PU, we can see definitely with patient with PU, they have significantly lower phase angle. This is expected. So now we want to look whether by using the phase angle, it can predict all the criteria that has been outlined by SRNM criteria just now. So we found out that phase angle can actually predict 2 out of the 7 PEW criteria that has been specified. Yeah. And from there, we also come out with a gender-specific phase angle with the discussed cutoff point that we can use in our population. Yeah. For men, for instance, 4.26 degree, and for female is 3.3 degree. Yeah. Of course, we will expect that males will have higher proportion of muscle mass as compared to female, right? So having said that, by using phase angle, we will be able to actually predict the risk of protein energy wasting among our dialysis population. And again, this has to population specific. Yeah, we did among multi-ethnic Malaysian group. In Malaysia, we comprise of Malay, Chinese, and Indian patients, right? So then we can also use BIA in order to look at the fluid overload among your patient, right? Because we know that in taking care of our kidney patient, for instance, one of the frustration is the fact that in terms of adherence to fluid restriction and also dietary restriction, we had the lowest compared to the other components such as medication and the treatment per se. So I'm just going to go a bit quickly with the fact that we found that in one single center study, fluid overload was reported all the way up to 45%. And we know that the consequences of fluid overload is fatal, including edema, ascites pulmonary edema, increase in left ventricular hypertrophy, and at the end of the day, increased risk of mortality. Um, so these are some clinical signs of fluid status among dialysis patients that we dietitian usually we can do this using nutrition focused physical examination to identify whether or not your patients experience fluid overload. But most of the time, uh, those with mild fluid overload, we cannot really identify them based on this phenotypic aspect. Yeah. So they can be fluid overload, but yet they don't really exhibit all of these criteria. But how to we can use the BIA in order to assess food overload for our population. For instance, we can use this is the parameters that we can use to assess food overload. You can look at the ratio of ECW to total body water. Yeah, you don't want it to be more than 45%, otherwise it will be food overload. Um, and there are some cutoff point for genders as well, right? So another aspect that we can look at for your BIA machines, if you have it in your institution, is that you can look at the BIVA plot, for instance, here, the movement of this plot, yeah. For instance, here you can look at they measure the pre and post dialysis. You can see the movement here towards towards this dehydration from left to right quadrant here. Yeah. So that's mean that has been the fluid has been excreted adequately, but you can see here the movement is so very little, so you may have to investigate further for this patient. They may still feel having fluid overload even after dialysis. Okay,
Dr.
so
Zulf,
how
can we
effective,
ask you to close in another 3 minutes?
right? So this
Yeah.
is my last slide. All right.
Oh, yeah.
Yeah.
Okay.
So how effective is bioelectrical impedance in order for us to control the fluid overload? So, this research has found that the primary endpoint is 1 year patient survival. So they have seen that 96% uh, um, effective for this population. All right. So some of the take-home message that I would like to highlight about the use of BIA is seem to be a convenient way, especially if your center, like in Malaysia, for instance, we're talking about dialysis center. 50% of our dialysis center don't have dietitian. So in order for you to assess protein energy wasting, you will require those skills in order to diagnose them. But if you have those BIA instrument, you can simply use that in order to find out which patient are at risk and do further intervention for this kind of patient. And I think my colleagues later on will talk about what are the intervention that we can do in order to address these protein energy wasting issues among this population. Was that? Thank you very much.
Thank you. A big thank you, Dr. Zulf. Very excellent session, very educative and very enlightening. We'll have some questions for you at the end of the session on how to do it. We have to understand it more in detail. Would like to now invite Professor Dr. Tilkawati. She is SRI Professor, School of Biosciences, Faculty of Health and Medical Sciences, Taylor's University, Lakeside Campus in Malaysia. She has a lot of publications to her credit. Was formerly Professor and Head of Dietetics Program, University Malaysia. She was appointed as Strategic Research Interests Professor at the School of Biosciences, and she has a whole lot of publication. She contributes towards legislation, clinical practice, education, and research in the field of cardiovascular and renal nutrition in Malaysia. Her agenda is to address double issues related to preventive of NCDs and in generating ethnic-based dietary evidence on cardiometabolic risk and technical reports. So she's, of course, got a whole lot of grants and contributors as speakers with 81 peer-reviewed publications, expert consultant and expert member of Evaluation Advisory Committee, expert and member of the International Advisory Group of Academy of Nutrition and Dietetics US, expert consultant in the Ministry of Health, member expert panel on nutrition Malaysia dialysis, vice chairperson. Oh my, it's got a huge line. External reviewer for project in Hong Kong and project in the Canadian government. So over to you, Dr. Tilkawati. If I take more time, I think the session will have to end here. So over to you.
Thank you, Dr. Anita, for your kind introduction. I will actually take up from my talk is going to be entirely on treating malnutrition, the approaches, and I think as dietitians, all of you do our concerned with this aspect, but I'm going to talk about the signs of it, what goes on in our practice, and what we can do to ensure that we stay on the path of good practice. Now, this is my disclosure. I do provide consultation. I have received grants from medical companies, but especially for patient education, research grants, and travel grants. Now, my talk outline is going to be entirely on malnutrition because that's a major issue. And we need to understand the nature of malnutrition. Dr. Zul has emphasized that. I will just touch a little bit on that, the kind of malnutrition that we are seeing commonly. And then I'll go straight into the malnutrition treatment approaches. And the big question is, does nutrition support work? I think that's important because many of you might have had touch and go aspects of tackling malnutrition in CKD patients. What are the outcome measurements and what are the issues related to that? I think that's very important. And the other approaches that we are doing a lot of work on to ensure that how can we buttress nutrition support for these patients? Now, Dr. Zul talked about understanding the development of malnutrition. I think that's very critical if we talk about hemodialysis patients because we need to know where it comes from. And as he showed you a similar diagram, but I'll just be very brief. It's very important for us to understand that a major aspect of malnutrition is iatrogenic. Those of you who are doing a lot of nutrition support understand that term iatrogenic. That means it cannot be controlled by us dietitians. It comes through medical procedure. But the upshot of it is that because of the dialysis machine, patients will have huge losses of nutrients, and that is continuous. Now, apart from that, on the green side is the aspects that we dietitians are handling. And no matter how much we are pushing our patients to eat, it seems that it becomes a big uphill task. And one of the major reasons that we have to be careful about is the occurrence of gluconeogenesis, because this yin and yang, the adequacy of energy, enough to ensure there's protein insurance to prevent muscle degradation is a big task for us dietitians. It's a very, very big task. The central core that we have to worry about is the what is going on internally. Okay, what we put the core highlights here in gray: inflammation, metabolic acidosis, uremia, because this actually tends to act against whatever patients are consuming. And this is the aspect that we have to consider. What is the impact of nutrition support? Can it change the outlook of the internal pathways that is going on that are contributing to muscle breakdown? So the overall aspect is when we talk about malnutrition, we have to be prepared to understand that on one side, we need to keep in touch with what's going on in the dialysis unit, and as well as whether the clinical picture of malnutrition, the internal aspects, inflammation, looking at the acidosis aspects, monitoring that is very critical. Now, as Dr. Zul mentioned, here it seems a very slow movement of my slide. Okay. Now, overall, globally, the protein energy wasting, that's the recognized, I would call it the recognized form of malnutrition, is about 43%. In Malaysia, we have a number for 23%. Now, the Malaysian number is much lower than the earlier dietary studies that came out, because this 23% is the data that comes with a screening of a larger number of patients. Now, the whole aspect of protein energy wasting is poor muscle function in patients, and the association is in frequency of hospitalization and higher aspect of mortality. Now, as the patient, but despite that, what we are concerned about is how are we dealing with patients here? We need to look at muscle wasting, and that's in the lifetime of the patient. And in essence, it's a skeletal muscle that that has been broken down. The skeletal muscle is the source of energy for gluconeogenesis, and it's also the source of amino acids to maintain protein synthesis, irrespective of how much protein is consumed or protein is broken down. The body has to keep maintaining protein synthesis. That's the ultimate aspect. So that's the aspect that we need to deal with. Now, in the lifetime of the patient, the poor muscle strength is measured by hand grip strength. Dr. Zul talked about hand grip strength. Any patient reporting a poor hand grip strength is also having a poor quality of life. And we see that very clearly in our patient. And whether we are measuring quality of life using at the SF, the short form 36, or the more specific kidney quality of life measures, irrespective of that, the physical component shows very clearly that patients have a very poor quality of life. And this is attributed to the minor loss of muscle contractile protein. So the ability of patients to perform simple aspects, to walk around, to move, to have the energy to work, all relates to this. Now, when we talk about treating protein energy wasting with nutrition support, both nutrition counseling and the second aspect, oral supplementation, are considered as first line treatments here. And when this doesn't work, then the intradialectic parenteral nutrition is suggested. So this suggests that the decision to treat protein energy wasting with nutrition support must go through the monitoring procedure that Dr. Zul talked about very clearly, the assessment of nutritional support, ensuring that dialysis management, the dialysis procedure is optimized. So that's an aspect that dietitians have to be cognizant with. Understanding the comorbidities, ensuring that the patient is stable and regularly following up with the dietitian, that's very critical. And when there's a need for nutritional intervention, that's the next step. That's automatically oral nutrition supplementation. There's a very clear guidelines how much is important. And wherever the patient's dietary protein intake is falling below 1 gram per kilogram per day, or the energy intake is falling below 30 kilocalories. So assessment is very critical here. Apart from that, where serum albumin is falling below 3.8 grams per deciliter, or well, very rarely in hospital practice we do pre-albumin. And also the unintentional weight loss of more than 5% over 3 months. And of course, identifying malnutrition using the subjective global assessment or the malnutrition inflammation score. So that becomes the need for oral supplementation. But if this fails to achieve, then there has to be a move towards IDPN. Now, talking about the first line here. When should we provide oral nutrition supplementation? As explained in the algorithm, the clear indicators when nutrition counseling is not sufficient is when the patient is reporting a poor appetite. Yes, this is something as simple as how is your appetite? A single question. And here, where the protein intake is falling below 1.2, dietary energy intake below 30 kilocalories, but serum albumin. So again, we bring this into play, unintentional weight loss. And whether you as a dietitian have also set other nutritional markers and you see that the markers are going down. Okay, the subjective global assessment is a very valuable tool to do it. So this becomes a reason for ONS prescription. Now, we have some evidence to look at the efficacy of managing the oral nutrition supplementation. Here we have just targeted what is the status of muscle response, because the whole aspect about protein energy wasting is muscle breakdown. So feeding, does that respond to muscle improvement? That's a very important aspect. And we use a multi-center randomized open label control trial with a commercial formula. Now, we had 16 dialysis centers participating here, and essentially consenting patients were all patients identified with protein energy wasting. We use block randomization to ensure there's no bias in patient recruitment. And randomization was patients were either receiving oral nutrition supplementation with nutrition counseling, or the control group was where they only received nutrition counseling. How long? We were providing them for about 6 months, and we use a renal specific ONS, providing about roughly 500 kilocalories and about 22 grams of protein per day. Now, the data collection. Here, this is what it seems very detailed, but you will understand why we need to do it. So the typical anthropometry, as Dr. Zul highlighted, the mid-arm circumference, the triceps, mid-arm muscle circumference, mid-arm muscle area, body composition. That means we use the BIS. It's easy for us because all dialysis units were having this machine. The biochemistry profile here, the full renal profile, lipid profile, liver function test, inflammation markers for hsCRP and interleukin, insulin, HOMA-IR scores, as well as the serum bicarb status, dietary intake, which is very critical, as well as appetite assessment, malnutrition status. We use MIS scores, as well as a quality of life measurement. Physical functioning, we're looking at hand grip strength, and we added something called ultrasound imaging. I will talk about it much later. And we also were interested in seeing how well the patients were taking the supplements. So we looked at compliance, supplement acceptance, and adverse events. Data collection was at baseline, 3rd month, and 6 months of study. Now, how did we give the ONS? On dialysis days, we provide the supplement one serving during dialysis 30 minutes after the dialysis starts, or if the patient did not feel like consuming it, they took it home for consumption. On non-dialysis days, consumption was after main meals or before bedtime, or if they felt they were unable to finish it, then they divided into 2 small portions taken between meals, and one of which was taken before bedtime. Now, the ability to finish one meager Tetra Pak is a big challenge for protein energy wasting because they have very low satiety. And this, as a dietitian, this is an aspect that you have to tackle with patients. Now, what are the results? Well, we see the red line represents the group receiving the ONS with nutrition counseling, and the blue line represents only nutrition counseling. And we see that there is a significant difference in terms of the energy intake. It goes up by the 3rd month and then slightly comes down by the 6 months. But within those receiving only counseling, we don't see much change, not significant at all. In terms of dietary protein intake, a similar increase came in with the supplementation added to whatever they were consuming, whereas those on counseling did not seem to show any improvement. The biggest change comes by 3rd month, but by 6 months, you see the patients faltering. Okay, so we are talking about adequacy, dietary adequacy. Well, that's measured in terms of kilocalories per kilogram ideal body weight for DEI and grams per kilogram ideal body weight for dietary protein intake. And you can see here there's a big jump. Now, this is both groups were asked to consume food as usual, but in addition, the ONS group had that extra Tetra Pak to take a day, and you can see the big jump here in terms of calories as well as protein. Now, we also measure the normalized protein catabolic rate, and because there's a greater influx of protein coming in, the rate goes up higher for those receiving the ONS, as you see. Now, this is not detrimental, but it's an important aspect of looking at improved protein intake. Or rather, I should use the word increased dietary intake. Now, we see increases, the BMI is much higher for those receiving ONS, that's significant. Whereas those on counseling, even though there's an improvement with counseling, it's not a significant rise. Now, the use of measuring dry weight is very important in these patients because they carry a lot of excess fluids. So we rely on the BIS, the bioimpedance machine, for this input, and you can see a clear picture over there. The significance improve with dry weight compared to the counseling group, and you can see that that's very low. Now, what about the other measures of body composition? Well, these arm circumference, the body composition, muscle strength, generally the treatment response. Now, here you see the ONS group, and here you see the counseling group only. Essentially, the treatment responses for the muscle indices, the MAMC, MAMA, the BI, the bioimpedance derived muscle measures, and the hand grip strength all were not significantly different. We couldn't see any difference between these two groups. Now, except for the mid-arm muscle circumference and the mid-arm muscle area, which showed some improvement at the 3rd month, but you don't see this at the 6th month. For the counseling group, we don't see any changes at all. Now, what about serum albumin? We don't see any, it's not significantly different between treatment groups as you see here. So we don't seem to see a picture here. One of the reasons why is the inflammation was very high here for the patient. So a non-significant, although there is a trend of increase for ONS at the 3rd month, it is not significant. Now, what about, we measured serum prealbumin. Now, prealbumin is not a standard measure for dialysis patients in dialysis unit, but we included this, and we see that prealbumin held steady right at the top, the dark black the black dots here that indicates the group receiving ONS, and that's significantly different. So we could see very clearly that prealbumin intake, which is a more stable measure of protein synthesis and storage, compared to serum albumin, there is response here compared to the counseling group. What about malnutrition inflammation score? Well, you can see it coming down for the group on receiving ONS, and that's significant. That red line below, whereas for the group on counseling, you can see there's a slight increasing trend, even though it is not significant. What is the actual effect of ONS treatment on Pew criteria status? Dr. Zul walked you through the diagnostic criteria. There are 4. We only see improvement for 1, that is the intake that you see here, the dietary energy intake. We see that it has improved by the 6th month here. For the ONS group, it's gone up. But there's a lesser number of patients. From 18, it dropped to 7. Whereas for the group receiving only counseling, from 21, it became 19. Yeah. So you have an idea that some measurements are working, some are not working. But the other aspect that dietitians need to monitor is the compliance and acceptance. We found that we have a very good compliance, more than 80%, and in terms of the acceptance of the product, all in terms of taste, flavor, portion size, odor, no adverse events, well accepted. Portion size, this is where, and satiety is where we have what you call patients were not happy with that product. Now, the views about oral nutrition supplementations. Dietitians are critical to performing nutrition assessment and making the decision on the nutrition support pathways. That's very clear. Counseling does yield benefits, but the success depends on intense monitoring of outcomes. That should relate to muscle improvement. So, this is something that dietitians must consider when we give supplementation. Is there an improvement in muscle? Often, the metabolic disturbance the patient has is likely to uh, disturb the ability of the patient to achieve energy and protein consumption. So the use of oral nutrition supplements must factor in also how long can the patient consume it? Is it long enough to show benefit? And the benefit must relate to increase in lean tissue mass. And compliance and adequacy should be monitored. Now, what about the second option, IDPN? Now, IDPN as a treatment for PU has been recommended by the ISRNM. It's proposed that it should be used after ONS failure. I won't go into it, but you should read about this. Now, there are clear indications for IDPN use when ONS is not working, there's a gut failure, patient is refusing to accept the product, they can't tolerate the smell or taste, and all this, and ability to keep the patient on those flavors for a long time. Now, what's critical is the use of IDPN needs a dietitian collaboration. That's very important because of necessity for assessing the patient's nutritional intake, particularly the oral intake, and measuring DEI and DPI. These are the monitoring outcomes that are critical. Now, there are guidelines in terms of the use of IDPN, but what's important is to look at there are several agencies here, and they all recognize that when should it be used? When oral protein intake is dropping, when oral calorie intake is dropping, as you see here. Now, here's a trial that we had testing IDPN use. Just like the ONS study, we had a multi-center, but we used 5 hemodialysis centers. All these were patients with PU, and we used block randomizations. And just like the ONS, we had an intervention group where counseling was combined with IDPN, and the control group, which received only counseling. Now, these are subjects, about 23 for the IDPN group and 21 for counseling. We provided a commercial IDPN product, which was essentially a lipid-based formula. About in range, we were feeding about 500 to about 800 ml, depending upon the fluid management for the patient. This is all standard electrolytes. On average, patients were receiving about 300 kilocalories per day with about 0.3 grams per day for protein. Now, IDPN could only be provided when patients come in to die life. So that means 3 times a week, unlike the ONS where we were giving daily. Now, the nurse is a very critical person here. One of the reasons why is in terms of the administration, managing the infusion sets, the infusion pump, the IDPN bag, the flow rate, and ensuring the monitoring of all these parameters are very important. So nurses are very critical. The data collection is similar to what we had, but in addition, we had the nurse coming in to help us monitor. Data collection was run at baseline, 3rd, and 6 months. So, and there's vast improvement in energy intake and protein intake, where IDPN is provided. Despite giving 3 times a week, we still see that there's a higher intake. And how much is in terms of adequacy, you can see for IDPN, we are not reaching as much as ONS, but slightly under 30 calories. DPI well over the protein requirement. So that's good here. Unlike the counseling group, where the dietary energy intake was well below 25 kilocalories and the DPI is well below 1 gram. Now, what are the changes we see a BMI improvement in the group receiving IDPN, a straight line up there from 3rd month to 6 months, and the dry weight improvement. So very clearly, there are improvements you see with IDPN use. You don't see that with counseling. Now, what about lean tissue mass and changes in fat tissue mass? Now, it's very funny. We see a different picture here, which is unique to IDPN, because this entirely reflects the lipid formulation of the IDPN formula here. And you can see that the fat tissue mass accretion has increased tremendously for the IDPN group. Now, serum albumin, we don't see anything here. Serum prealbumin, we do see a non-significant increase in prealbumin. Interleukin 6 indicates that the inflammation is very high. Now, there is, what about the MIS scores? Yes, we see a drastic drop in the MIS scores, which indicates that inflammation is coming down, malnutrition inflammation is coming down with IDPN support compared to the counseling group. What about quality of life scores? This is significant here, as you see. So now, what about PEW prevalence? Yes, you see that after 6 months, the PEW prevalence has dropped to 35% for the group on IDPN, but with counseling, it came down to 65%. But unlike ONS, we have monitoring parameters to ensure stability, that is potassium and phosphate. This has got no nutritional significance, but it's an important aspect of monitoring. The problem that you see here is the serum triglycerides climbing up, reflecting the higher lipid formulation that is coming from the IDPN bag. The lipid emulsion source comes from IDPN. Okay. Now, what we see here with IDPN is there are great improvements in BMI and dry weight, but we don't see the picture for albumin and prealbumin. We are achieving adequacy for energy and protein, and PCR is correlating with DPI. We see improvements for MIS QOL. For appetite, we did see that some of our patients were picked up their oral nutrition, I would say their oral foods intake started increasing. Now, what we see here for some conclusions that we can see is dietitians are very much critical to performing nutrition assessment and monitoring dietary intake if IDPN is planned. Now, what we showed you here is IDPN use in outpatient settings, not warded. Nurses are critical to administration and monitoring. Provision of IDPN, we should very clearly improves PEW status. But the major problem would be IDPN cost is a key barrier. And if units lack a IDPN protocol, that is standard operating protocol, and there's a lack of dietitians in those units, implementation is impossible. Now, beyond that, I would like to talk about measuring outcomes from nutritional support. We have explored deeply here. Now, the criteria of diagnosis for PEW is serum chemistry, body mass, muscle mass, dietary intake. You're well aware of this. But the reality is here that there are many, many studies that have gone on to showing ONS use, and there are all these markers that are depending that we've talked about: albumin, body weight, lean body mass, muscle circumference, and so on. But we felt that the assessment of muscle wasting is not direct. Most of the measurements are indirect, but the direct methods such as your BIA, DEXA, or MRI are very expensive. Of course, the most important, your bioimpedance is an indirect way, but your DEXA and MRI are the direct methods which are expensive. Now, there's an additional measure that we used. We measured, unlike the upper arms that Dr. Zul was talking about, we included an additional measure looking at the mid-thigh muscle area. And we showed very clearly here that the mid-thigh girth is highly significant when measuring for ONS, provided compared to uh, just receiving counseling. As you can see, there's a significant increase in the girth measurement. So we proceeded to looking at measuring quadriceps muscles using ultrasound imaging, for which we are able to look at muscle thickness and cross-sectional area of the quadriceps muscles. And this is what we targeted in our measurements. And we were able to also develop the CSA metrics as per gender. And we find that this method is very low cost, but it requires setting up a protocol of measurement, landmarking, as Dr. Zul talked about Isaac, because you need to come back and measuring repeatedly. Now, what we saw here for the same ONS group, there were gains in quadricep muscle status when we use ultrasound approaches, and we see that as you see here, there are three sites that we show here: your rectus femoris, and of all these, the RFCSA we see is very, very clearly an easiest way of measuring. Now, the second aspect is metabolomics. Dr. Zul's group looked at running blood samples and checking for metabolites, and they were able to clearly separate specific metabolites. 3-hydroxybutyrate, acetate, arabinose, maltose, ribose, sucrose, and tartrates were found to be significantly increased in few patients compared to creatinine. And these few related metabolites clearly were indicative of fatty acid mechanisms, and also changes to the glyoxylate and the dicarboxylate pathways, which are connected to gluconeogenesis. So this was a study that they looked at when screening protein energy wasting. So this is a screening study. Now we went on to looking at what happens when we look at metabolomics for patients who are fed with ONS or IDPN. I will walk you through this very simply. Essentially, what we see here on the right is, on the red is the patients receiving ONS, and the green is the control. You can see some separation here. There's a certain behavior, but it's not significantly different at baseline. At 3 months, we see a clear separation from the control on the left and the ONS on the right. And on the 6 months, you see a further this maintenance of this scattering. What does this imply? Generally, the red metabolites are the significant markers. And these are the top 3 metabolites that we picked up: 2-oxoglutarate, 3-hydroxybutyrate, glutamate. For the treatment groups, those receiving ONS are only nutrition counseling. And we see significant differences turning up here. So for oxyglutarate, we can see a higher trend for those on oral supplementation, and this seems to be connected with gluconeogenesis. For 3-hydroxybutyrate, there's a decreased trend with ONS compared to an opposite trend for counseling. So the question is lower 3-hydroxybutyrate an indicator for better resolution of protein energy wasting? So in metabolomics, these are questions that are indicated. We need more answers. For glutamate, we see a higher trend for ONS. So is a higher trend indicative that gluconeogenesis is resolving? Now going on to IDPN, again, you see at baseline what you call a non-significant clustering at the center. But at 3 months, you start seeing separations. The green is the control, the blue is IDPN. And at 6 months, you see that separation still continuing. So what are the metabolites? We see 4: citrate, glutamate, leucine, taurine, significantly different between the two treatments. And the 2, citrate, seems to be higher for IDPN, is a higher citrate indicative of improving uremic status. Glutamate is this cognizant with resolving gluconeogenesis. Leucine is a higher leucine indicating again that there's a resolution of gluconeogenesis and also mitigating insulin resistance. Taurine is a higher glutamate indicating resolution of insulin resistance. So what we see here, some value points that you need to you can take here. Muscle improvement requires clear achievement of mitigating gluconeogenesis. Achieving energy and protein adequacy is very critical. The mid-thigh muscle or the quadriceps muscle is a good surrogate for measuring muscle improvement physically. Mid-thigh girth is all you need is a tape. But if you want to measure muscles, you need to be trained to do the ultrasound. Metabolic pathways clearly respond to nutrition support. As more metabolomics evidence develops, nutrition support should become standard operating protocol for hemodialysis patients diagnosed with protein energy wasting. Now we have the kind of data that I have showed and even Dr. Zul showed is greatly dependent on our patients, the nephrology community in Malaysia who have extended their support to us, the Ministry of Health Public Hospitals, the National Kidney Foundation, the National Renal Registry, and our institutions. Now, apart from that, we have received funding majorly from for the patch study, which comes from the Government of Malaysia, the Malaysian Palm Oil Board, NKF Malaysia, government funding, scholarships provided by our 3 institutions. On the right are people whom we have networked with and worked with in our projects. This is, we have actually a very large group of across institutions as well as our postgraduate students here with us. Now, PATCH was a big study which enabled us to do this kind of work. We began in 2016. It's a collaboration between Malaysia and the United States, and we extended it to Bangladesh and India. I won't go further in this, but generally, out of almost 500 hemodialysis patients from 14 dialysis centers in Malaysia, we were able to do a big study evaluating nutrition supplementation. Thank you. With that, I will stop sharing.
Very nice lectures given by Dr. Tilkawati ji. And in fact, we have very good lectures, very enriching by both the speakers. First one was on diagnostic assessment. They have given a new ways, new modalities to check malnutrition in chronic kidney disease. And Madam in the second lecture has very nicely covered the management, especially the IDPL part on outpatient basis in that. So now we can go ahead with the questions.
Okay. I see there's a question
in the chat.
Why we use a single brand? Well, that's research. We can't use 2 or 3 unless we for every. Can I read this question?
Yeah, please, Dr. Tilkawati. Yeah, go ahead. Yeah.
About why we use only one brand for all patients. Well, when you run research, you need sampling sufficiency, and to run these trials are expensive. So, of course, it'll be good to have 2 or 3 brands. Now, this is an investigator initiative. The brand, the product is not what you call, this is not a company supported project. It's an investigator initiative. And we what you call, open the tender for all companies with renal specific products to think. And essentially, we are looking at energy and protein. So any of the products that fit into that is what we choose. The brand does not make a difference. Whether it's got enough calories, enough protein, and the deciding factor is the cost because we are paying for it. So whoever is cheaper, we select. And we can only do one. Ideally, yes, we should do whatever brands there are. If you have the money, you should run. But please take note, in India, you probably get enough patient number, sampling size. We have a smaller number. This is a smaller country. But despite, we have to use a block randomization. And probably you can be, with Apollo, you should be able to, I would say, just using Apollo as an example, you have so many hospitals. So you should be able to get that. But when you run a brand, when you have 2 or 3 brands, you must ensure that your subjects or your patients are blinded to it. You've got to fulfill that research criteria. So again, you can choose one brand in Delhi and another in Chennai, etc. So
We'll
Ma'am, a
connect with
question
you.
to you. Yeah.
Babita, over to you. Yeah.
Yeah. I just, ma'am, you have talked about IDP and you talked about ONS. Can you highlight a bit on the keto analogs that are being used? What is your take on that?
okay, our objective was in terms of improving muscle wasting.
Okay.
And the bulk of management is always in terms of cost and how long can you get. So uh, your keto analogs are only delivering I would say a
Essential.
very tiny fraction of amino acids, but gluconeogenesis is the essence, and you need to ensure energy is also going in. we had uh, we had run a pure protein supplement study for peritoneal dialysis a few years back. That's how we started. And yes, and we use the standard ways of measuring. And we at the end of the day, we hardly see. I talked about outcomes. Most studies you may not see outcomes. That's very important. And if you want to bring in a standard protocol, your hospital administrator or your board may say, what is the evidence? So studies will show different results, but at the end of it is in terms of what are you going to choose to measure. So the peritoneal dialysis study showed us, one, managing fluid status is very difficult, as Dr. Zul talks about. We were trying to guess the dry weight of a PD patient is worse than for hemodialysis. So if you're not sure of the weight, your your albumin values will be very narrow. So the more fluid they have, your albumin values are small. We didn't have the money to do pre-albumin.
Oh, more
Secondly,
expensive.
we found that patients' DPI went up very well, but we weren't providing extra calories. And we couldn't check on metabolomics like what Dr. Zul's group did.
Okay.
So we learn from our mistakes. But energy is very critical. And the feedback we gave was, if you want to provide a protein only product for the aim of improving muscles, weight, etc., you need to ensure energy sufficiency. That's the bottom rule. This is like Newton's law.
Yeah.
There are more questions in the
So I
chat
think,
box, Babita.
no, there aren't any
Yeah, there is
questions.
one in IDPN. What is the protein and carbohydrate percentage?
Well, let me, I can read it out to you.
Okay.
Just a minute. Just give me a minute. Any other questions while you talk?
Yeah, Dr. Zulf, I'd like to know what are your SOPs that you follow in your dialysis? How often do you do nutritional assessment for patients who are coming weekly, bi-weekly, monthly? What are your SOPs there?
Okay. First, if you can refer to the latest guideline by Kedoki, guideline in 2020, we can do a body composition assessment for a stable patient every 6 months. You can do
Okay.
that.
So
Yeah.
BIA is how often?
That's BIA what I mean. Yeah, body
Okay, for
composition
once in six
using
months.
BIA. Yeah, every 6 months.
But what is the general SOPs? I mean, just a general, what do you do when a patient checks in for dialysis?
Okay, a few things here. Before I go for that, because I saw just a question with regard to what are specific instrument that you use for BIA. First, as I highlighted just now, only a multi-frequency BIA can has an option for you to get the phase angle value. So you want to make sure that the instrument that you're using is actually a phase angle. But of course, there are many manufacturers like InBody, S10, and then Seca 525, and then we have from Fresenius as well. So all of these can give you a phase angle for you to get that cutoff point. Second, in terms of the SOP, so basically, we can actually do that towards the for that hemodialysis. We usually because in our centers, patients are sitting on the chair that can be flattened, so we can use that
Okay.
towards the end of the dialysis treatment. Yes. For peritoneal dialysis, um, it is indicated that patient in the manufacturer SOP is indicated that the patient has to drain out the dialysate solution first before you do the measurements. But we did actually we are in the process of publication that because that is not really pragmatic because patient have to drain out their dialysate fluid, right? So we found out whether what would be the difference when patient drain out the fluid and not draining out the fluid and so on, and we found that there's no clinical significant or clinical difference in that. So you
Okay.
can measure the patient as it is when they come to the clinic. Yeah.
Okay. And Dr. Thilkavati, who does the ultrasound for you in your hospitals? Are the dietitians allowed to do it
No,
or assessment?
okay. Okay. Before that, let me answer that
That
question
question, yeah, the IDPM, yeah.
yeah. So if you take a look at the box on the right here, top right, depending upon the volume, if it's a 500 ml volume, that's about 27 grams of protein. It's got to be dextrose of 72 grams, and your fat is 20 grams. So when you're moving up 600, 800, this will increase. So if they are receiving about 800 plus, protein is about 49, dextrose 122, and fat 34. So you can work your percentage. But to be over the course of time, we found that we could never run 800. It's usually between 500 to 600 that we were
600.
running. Yeah. So to answer your question that you're talking about, the ultrasound,
Yeah, who
you
does
saw a
it? Are you
picture.
allowed?
Yeah.
Yeah.
Yes, we can. That's why shouldn't
We've
why
not, yeah,
shouldn't
we've
we
been
do it?
wanting to initiate it, but I don't know if we are allowed as, dietitians and
Okay.
not being doctors.
Yes, no.
So you're doing
Actually,
it there.
I showed a picture here that you saw a group of us. Let me see.
So great. I think we
Hmm.
should take this initiative here too. We've been wanting to do
We've
it
had
for
a
a
lot of
very long time.
adventures, I must tell you.
Yeah.
Yeah,
But you have to be trained, and you
Yeah.
have
So
to
we
be
can get
trained.
trained. I mean,
yeah,
what is it so difficult that we can't understand?
not difficult at all.
Yeah, I think so.
Not difficult at all.
Yeah, hands
Yeah.
down, I think we'll take a training from you.
No, we can. Okay, wait.
You should, and you're doing the muscle measurement.
Yeah. Okay,
So are
this
you
one.
doing it for all your patients?
Yes, we did. Okay, let me get this
Is that a
done.
protocol?
Okay,
Is that
yes,
a protocol
yes.
with you?
There is a protocol. There is a
Yeah, all
protocol. We
right.
have
Okay.
papers. We can the protocols
Yeah, I
are
saw that. Yeah.
detailed here. But you see, you have to have training. The picture that you see on the right, you see besides Dr. Zul and myself, we had students at that time, Sharmila. There are three of them. This was taken, Sharmila, the pharmacist, that is Birin, who did IDPN. Sharmila did ONS, and we have one more. You can't see him. And this is Alice. Alice is a dietitian. She was training us.
Okay.
Well,
Wow.
we did it at University of Parma under
Okay.
Enrico Fiaccadori. Those of you who are familiar with acute kidney injury should know Enrico Fiaccadori's name. And when I asked him about the potential of looking at IDPN, he suggested that our group visit him for the training, which we did. Okay, but the protocol, in addition to what we learned from them, we added in the ISAC to ensure, because we were doing repeated measures. We are planning to do repeated measures. That means we have to get back to the same mid-thigh circumference. So we added
Okay.
landmarking as a protocol.
All right.
And it's not a problem. We can actually do the training for you all. You need a portable.
We'll take you on that.
Ultrasound. We were
Yeah,
using a
we'll.
portable
Yeah,
ultrasound.
Tilkavati, I'm going to take that offer of yours.
Yeah, just to mention to you, they used a standard ultrasound machine that you get in the hospital. So Alice had a very old one that was rejected by the others. So they had to scrounge around the hospital to get one. So we managed to buy from uh, a portable one, a second-hand portable one for our project. But now the technology has changed so much. It's very small. You
Okay.
just link it to your laptop.
Wow.
You know?
Oh, that's
Yeah.
great.
Yeah.
So we'll take you on your offer. And a big
Yeah.
thank you. Any other questions,
There
Kavita?
are no other questions. There are
Yeah,
no
all
other
right.
questions, ma'am.
Yeah,
And I
but
think this session has really helped in guiding all the participants here, like through the essential steps in developing a healthy nutritional care plan and in achieving the patient nutritional goals. Definitely here, when we talk about malnutrition, the dietitian's role is of the utmost importance because assessment is important. Unless and until you assess the patient, right? So you cannot have a proper care plan, right? And the use of the dietary interventions here will definitely improve the nutritional outcome of the patient, because we have seen, as both the speakers had said, that a large number of maybe 50% of the dialysis patients are malnourished, and the rates in India are alarming. It shows around 65% are malnourished, right? So
You
why
got to
not
take
be
it with a pinch of
proactive?
salt. That 80%, you got to take it with a pinch of salt. You need to do the groundwork.
That
Apollo
is
has
what
got a huge number of
yes,
patients, so
yes.
you
So I
can
think
train.
yes, and
You
and
can
being,
train a core group, get your data, and see.
yes, we shall. With all your guidance, we will need all your help to form,
yes, and we're going to,
I think,
we're going to take you on your
yeah,
offer.
we'll take it forward. And I think being proactive is of the utmost important. Not take care when the patient is midway, already malnourished. Why not be a little bit proactive? And I think nutrition counseling is very, very
Important.
important.
Very, very
Yeah.
important.
Thank you so much
All
See,
right.
I want to see, I want to
to
mention to you that
yeah.
what we see with IDPN is they really need to reformulate IDPN.
Mhm.
You
Okay.
need IDPN, but you see the product needs to be changed, the formulation.
Okay.
When we publish it, probably that data will go out. Dr. Anita, could
Yeah.
I add something else? This is since we have a large group here. I would like to, uh, sorry, okay. since we are here, I want to talk about have you all heard about the Global Renal Internet course for Dietitians Grid?
Okay,
This is
that's
managed
interesting. I
by,
wish you had shown it earlier before people had logged out, but still they are there.
I will send the slides to you, Dr.
Yeah, I
Anita,
will.
to please share.
I will put it in my
We are
groups.
advertising for this is an advanced grid course, and it's very useful in terms of upgrading our knowledge.
It's
And
online,
it
Dr.
comes
Tilkavati. Is it
it's
online?
it's entirely online.
Okay, great.
And it comes as 3 modules. We have an executive committee and members, and the most important aspect is that you have the basics, nutritional basics, and we have gone on to module 2, the which is looking at NCP applications for dietitian pathways. So module 1 is very technical, it's very medical knowledge aspects. It's very advanced, which should benefit dietitians who are dealing. This course is meant for dietitians.
I'll share it with the Apollo group and with the other groups.
I'll send this to you all.
Just send me
now,
this as
case-based topics.
Yeah.
Okay.
That.
So, and what is important is the membership, the cost per module will be about 100 for those coming in from developing countries. Okay, so it is there, and it's like a university curriculum. It comes about 20 plus topics. Each topic has got a little exam, and when you get above a certain point,
get a certificate.
You get a certificate and you get points for evaluation.
All right.
Yeah.
Thank you. And a big thank you to our speakers. Excellent session. Very, very educative.
Thank you. Thank you, Dr. Anita, for giving the opportunity. Thank you.
Thank you so much, Dr. Sandeep and Babita, for moderating and sharing the session.
Wonderful session.
Yeah.
Thank you.
Okay, thank you
to
so
the
much.
organizing committee and to the president of GAPIO, who's Dr. Nanda Kumar Jairam. Thank you to everybody. Thank you, Dr. Tilkavati and Dr. Zulf, as you like to be called. A big, big thank you. Accepting the invite on a Saturday evening. That's a big thank you.
What I would like to add, a point I would like to add is that it's good for us dietitians to work across our profession.
Yes.
That way we can collaborate and do much more for our patients. That's very important.
And a big thank you to Dr. Kanta, who's always there. Dr. Sharma, thank you. Yeah, she's so always involved. Thank you so much. All right, good evening, and we'll catch you independently, Dr. Tilkavati. Bye. Thank you. Bye.
Yeah.
Thank you. Bye.
Bye. Bye.
Bye. Thank you.
Thank you, Dr. Zulf.
Wonderful.